Okay, let's talk about fibrocartilage and menisci for a moment. All fibrocartilaginous meniscal structures develop signal with age. It's a diffusional event. Most fibrocartilaginous structures are made up of layers, circumferential layers, annular layers, radial layers, central layers. And as you get older, things get a little more loose. And as they do, you get diffusion of fluid in that joint into that structure. Or sometimes it's just a product of mild edema from repetitive mechanical factors, including impaction and torque. So it's not uncommon in fact, it's common in 40 and 50-year-olds to see some ill-defined central signal in menisci of knee or menisci of the hip. The causes of intrameniscal signal besides this effect of wear and tear or impaction or diffusion include actual true contusion. You would make that diagnosis when you have trauma over the meniscus. Pretty hard to have a meniscal contusion and a normal cartilage and a normal bone over top of it. So if the meniscus looks a little swollen with exaggerated ill-defined signal and you have a bone injury right next to it, okay, that's fine. But most important is the normal meniscal vascularity of the juvenile. If you call that a tear, you are creating a disaster for a child. Read meniscal tears in children very, very conservatively. In fact, you should probably, if you're not a pediatric or an MSK radiologist, you should probably not even read them unless there's a discoid meniscus or unless it's just the most amazing, gross example of meniscal tear you've ever seen. Intrameniscal tears, when do you make that read? When you have signal in the inner third that's preferentially in the inner third and or it's creating a meniscal cyst. Some other causes of meniscal signal include meniscal ossicles, which are probably acquired bleeds that ossify in the menisci, CPPD, gout, inflammation, sometimes meniscal flounce. In other words, the meniscal edge is rather wavy like this, and it gets pushed back by some synovium and capsule, and then it even gets bent a little bit, folded a little bit like a bow tie, and it's truncated at its edge. That's very common, especially with people that have synovial hypertrophy or a little bit of fluid, and it is said to be an indicator of a hypermobile meniscus. And then you have conversion signal. You're all sitting there thinking, what is conversion signal? Well, here's what happens when a surgeon decides to do a meniscectomy. Let's find a clear area to draw on. This will work. So now you have normal signal here. And then you also, with that, had some nasty tear. Let's say it was a radial tear. And the surgeon was pretty aggressive lady or gentleman. And so they went in there with their scalpel and they did this. They just wiped it out. They just cut it. And they said, oh, yeah, it's still bad. Still looks bad. Oh, it's still bad. Now it looks pretty good. I'll stop. Look what happens to the normal signal now. The normal signal is now communicating with the free edge of the trim meniscus. And that normal signal is going to get brighter because it's going to get banged around because it's now slightly unstable. Why is it unstable? The clinician destabilized it. It's true. They don't want to hear it, but they did. So I'm not chasing this unless the meniscus is twisted, there's locking, there's a cyst, there's maceration, it's extruded into the gutter. I'm not doing an arthrogram. Don't do arthrography for post-meniscectomy knees except in unusual extreme circumstances, maybe in a failed repair, where you have to know whether the sutural repair of a bucket handle tear is competent. That would be an indication. Well, we're not done yet. We're not done yet. All right, let's do it again. Remember, this is going to apply to any fibrocartilaginous structure. So now I've got my meniscus again this time. This time I have a really big tear. Got this really big blue tear. It's like this. Then it's got a radial component. It's just nasty. And the surgeon goes in there, and what do? They start cutting away. Cutting, and they say, okay, now we're in the vascular zone of the meniscus. We better stop. Because if we take the whole meniscus out, he's going to get a total knee replacement. Let's just leave that. Let's suture it, close it up. That's in the healing zone. We'll leave it alone. And now you see that, and you say, oh, my goodness, that's a complex tear. It's communicating with the free edge. It's a meniscal tear. He's had some trauma. He needs surgery. No, doesn't need surgery. Unless it's twisted, unless it's collapsed, unless there's a cyst, unless there's a piece broken off. That is conversion signal of a stable appearing chronic meniscus tear. Or you could say stable appearing chronic signal conversion type of a meniscus tear combined with normal myxoid intrameniscal signal or normal intrameniscal change of aging. You can word it any one of a number of ways, but you got to word it as it's a do not touch me conversion type signal phenomenon in the middle to outer third of the meniscus. Don't be chasing these. Don't be calling these out as tears to be reckoned with, because they hardly ever are. Most common cause of a patient with a meniscectomy who comes in with knee pain, arthritis. How soon? 3 months. That's how soon it takes to get arthritis after a meniscectomy. And I can prove it to you if you force me to do it. I can show you cases where 3 months later, in a 20-year-old boy, he's got arthritis after a meniscectomy. So the question is, they did a meniscectomy. They wiped out the inner third. We wiped out, let's say, half the meniscus, which is not uncommon. They took the inner half, and your question is now the patient presents with a new linear signal. Let's say you had a prior study and it wasn't there, and now the patient's developed this. Okay, fair enough. He's got a cleavage tear in the outer third, in the healing zone. If you take this out, total knee. So, you know what? It doesn't matter. How would you word it? New onset cleavage signal in the healing red zone, delicate, less than 1.5 centimeters in size, not associated with meniscal displacement or instability or cyst formation. Translation, if you deal with that, you're an idiot. That's how you say it. It's an excellent question, and it does come up. So I've given you some of the descriptors for meniscal tears already. I drew them for you. You can have intrameniscal cysts, extrameniscal cysts, flaps, buckets, separations, detachments, radial longitudinal tears, vertical longitudinal tears, and then you've got the causes of intrameniscal signal that we already discussed. Then this is a diagram showing you the different types of hip labral signal. And somebody has given them a stage, which I'd never use, and a shape, which I've never used, published in a paper, but we reproduced it for you because it simply illustrates what happens in normal aging, in wear and tear, and then in the significant or relevant traumatic scenario where in the hip you might have meniscocapsular diastasis, meniscoacetabular diastasis, or meniscochondral separation, which is one of the more common forms of traumatic, serious hip labral injury. They can be straight or they can be serrated. I believe we've diagrammatically covered the menisci of the knee. So I've given you some criteria when signal in menisci is not a tear, window framing, central, not vertical, fades in the inner third. It's not as bright as hyaline cartilage. It's not bright on T2. It doesn't touch an articular surface. When do you call out a meniscal abnormality as unstable? When it's very large, but size alone is not a criteria sufficient to warrant a meniscectomy. But if it is large, that's going to push you a little bit more towards digging for other signs of instability. So radial tears whose depth is greater than 8 millimeters from inner third to outer third. Length of greater than 3 to 4 centimeters. If the radial tear or any other tear is gapping, it's getting wider and wider and wider, or it's just wide. Because, if you have a vertical tear and it gets wide, it's going to be a bucket eventually. And I've seen them evolve. I've seen a hockey player, NFL hockey player, who had this. He's a goalie, and then 2 days later, giant bucket. So buckets are vertical tears that evolve. Is it full depth? Does the tear go all the way through, or does it just go partially through? Is it trizonal? Is it in the inner third, middle third, and outer third? Now, these have to be taken in their totality. Is there displacement, turning, twisting, migration? And does the patient have a history of locking? Here are all the causes of intrameniscal signal that I gave you before. 70-year-old man with pain for 1 month after a skiing injury. Let's start out with the axial first, which I usually do, by the way. So the axial, I start up high. One of the first things I do is I evaluate the distal footprint of the rotator cuff from anterior to posterior. The footprint is very complex. In fact, it's not completely parallel. See, that fiber is not parallel to that fiber. And frequently, the infraspinatus fibers will curl and come underneath the supraspinatus fibers, so they will overlap. There is some bursal fluid posteriorly. I'm working my way down, looking at the character of the humeral head. Is there a Hill-Sachs? No. Is there an impingement-type pseudocyst? There are innumerable ones. So the patient's probably an impinger. There's some in the front, external impingement. There's some in the back, internal impingement. This convention was generated by the French. That's why it makes no sense. But they have a really good European football team. So I noticed that there is degenerative change in the posterior labrum, very common in adults because all your life you're pushing, right? You're doing push-ups, you're pushing things away, you're pushing people away in sport. So it's very common to see small tears and erosions in the posterior glenoid in adults. So I'm going to comment on it as a chronic phenomenon, but it's not particularly alarming to me. I'm also going to comment on these chronic fissure-like anterior labral tears that don't belong there. They're certainly chronic in nature. The patient has not had a dislocation, even though he's had a skiing injury. If he had a dislocation, I'd see a Hill-Sachs. If he had a dislocation, I'd see swelling here. And then I look at the conformity. In other words, what's the shape of the humerus relative to the shape of the cup? They're pretty congruent, even though the patient is in slight external rotation. Then I look at the centering. Is the center of my humeral head lined up with the center of my glenoid? Yeah, pretty good. I'll also look at the centering in the coronal projection, and we'll show that in a moment. So the answer to that question, centering in both the AP and the coronal projection, is true. You want to check centering in both. Decentering this way is usually from instability, usually micro-instability, either anterior, posterior, or multi-directional instability. Let's keep going. In this projection, I'll check out the subscapularis. I'll see if it has a nice, tight footprint to the lesser tuberosity, and the answer is, no, it doesn't. That's not nice and tight. In fact, it's a little white. So the deep fibers of the subscapularis are delaminating, and that's called a medial pulley injury. And when that happens, that will allow, in some cases, the biceps to prematurely and medially exit, which this one is doing right now. And it's swollen too, you can hardly see it. It's falling into the arms of the subscapularis. Right? There's the biceps. There it is, falling into the arms, interstitially in the subscapularis. There it is. So there is a medial biceps pulley mechanism. There's delamination of the subscapularis. There's arthropathy, right? There's chondromalacia. There's posterior degenerative changes and chronic fissuring of the posterior labrum more than the anterior labrum. There's an effusion, there's bursal fluid, and there's signs of internal and external impingement as determined by the presence of impaction-related or friction-related pseudocysts posteriorly for internal impingement and anteriorly for external impingement, and we haven't looked at anything but the axial. Got a lot of information, didn't we? We've also deemed that the rotator cuff might be injured, but it's intact. The major fibers are still there of the supraspinatus and infraspinatus cuff. We could probably read the whole case off the axial if we wanted to. Let's put up the rest. I've got a sagittal and two coronals. Now, I like to have a coronal PD, and I do, a coronal T1 and a sagittal T2 with fat suppression, so I get a slightly different contrast character. And why is that? Well, because the T2, when you have a massive injury, tremendous swelling and edema and blood, and you can't see anything on the PD, the T2 often cleans it up. In other words, most of the tissues sort of fade down in signal, and you can see the edges of ligaments and tendons. So it's kind of a cleanup sequence. It also helps you to date. I don't mean like Bumble, like dating online. I mean date, as in, is it old or new? Like, I'm old, and some of the people in the back are new. So if it's old, dark on T2. If it's new, going to be bright on T2. So chronicity can be determined on the T2. It can also be your enemy. Why is that? Well, what's the signal of a tendon or a ligament? It's black. What's the signal of scar tissue? It's black. So what happens if you have a scar, tendon, or ligament connected and somewhat straight? You're going to read it as intact, even though it's really a false connection. Happens all the time. So you can't simply rely on the T2 to make the appropriate diagnosis of a partial tear, a full thickness tear, etc. So now I'm using this case to illustrate some verbiage, and I am intentionally, knowingly spending a lot of time on it. So we're going to determine whether our abnormality is old or new. If you're not sure, then a good out is subacute, intermediate age, right? You can't be wrong with that. Right? If it's subacute, you're close to chronic and you're close to acute. So, there's some get-out-of-jail-free cards that you can use. But this one is at least actively inflamed. Look how swollen it is. See if I can flatten it out a little bit to show to you. So the rotator cuff is abnormal. The reason we didn't perceive it in the axial is it wasn't really a full thickness tear. But it's at the footprint, and it's penetrating into the bone. We call that a rim rent. So we'd say it's a partial thickness footprint tear, distally positioned, with a rim rent component associated with reactive marrow edema. Period. Next paragraph. The tear is 3 millimeters wide by 7 millimeters long and lies just behind the most anterior fibers of the supraspinatus, surrounded by areas of interstitial tendon fiber swelling and or failure. In other words, where are all the tendrils, the subtendon units that are supposed to be in here? Where are these? They're effaced. So this isn't the only area of pathology. That's just where the tear has coalesced. And then I try and gauge the depth. And usually I'll try and assess whether it's greater than or less than 50% depth. Now, if I just looked at this, I'd say less than 50% depth, less than 50% depth. I also try and determine whether it's a vertical tear. In other words, is it going this way or is it going this way? Let's take those off. And it's kind of round until you scroll it. Wow. Horizontal. Is it really less than 50% depth? I don't think so. It's almost penetrating the bursal surface. So how would you word this? Do you need to do an arthrogram to see if there's extravasation of contrast? Hell no. That doesn't change anything. We did that for years because we were silly. It's all we knew. Habit. It's what we were taught by our mentors, great mentors. But we didn't really have the technology that we have today. So it doesn't matter whether that hole goes through or not. You're going to manage it the same way. This one's actively inflamed. This one is penetrating. A good get-out-of-jail-free card, near full thickness tear. Really, that works. You can say near full thickness or full thickness with surrounding tendon fibril failure, less than 1 centimeter in size, horizontally oriented at the footprint, inciting edema in the greater tuberosity with a rim rend component. Its medial lateral dimension you'd measure. Now it's about 9 millimeters. Its AP dimension or length about 7 to 9 millimeters. Are we there yet? No, we're not there yet. I mean, how did this patient get this tear? Probably as a byproduct of his trauma, but his trauma didn't cause all these cysts. They've been there for years. So he was an impinger to start with. He probably had tendinopathy and a degenerated tendon as a result, not of bone, that is not bone. Look at the T1, maybe a little bit of bone. Maybe a little bit right there. It mostly is the coracoacromial ligament. Pressing down on that. Well, you might say, well, why isn't it pressing down on that? It is when he picks his arm up. Every time the arm goes over the head, this thing rotates right into the CAL, coracoacromial ligament, and subacromial arch, and you get lateral subacromial arch impingement, one of the types of anatomic impingement. What are the other types? Coracoid impingement. Another type, medial impingement at the AC joint, which almost never occurs. And one last type, ASI, anterosuperior impingement. This is the most common, 90% of all anatomic impingement, right there. Who gets anatomic impingement? People that aren't 15 to 20 years old. As you get older, you develop anatomic changes and deformities and remodeling. So people that are 30, they have a combination of microinstability, humeral head goes up when you pick your arm up, doesn't stay depressed like it should, and they have abnormal bony architecture, or they have a thick CAL, and the two combine to give you impingement. Or when you're 20, you pick your arm up, the bones are normal, and this bumps into that because you have muscular imbalance. And when you're 70, it's almost always anatomic because you don't do enough vigorously to really generate microinstability. So there's more. The humeral head is slightly elevated. If we take this step off, it should be right down here. So the scapulohumeral line should line up with the inferior glenoid. There's humeral head elevation. There's some loss of the depressor mechanism. There's some glenoid deformity with glenoid slope. Right? The glenoid should be up and down like this. It's not. So while the conformity was normal in the axial projection, it's slightly altered in the coronal projection. So we do have some conformity change. We do have OA. And then finally, to cap it off, we look at the overall muscularity because you don't want to repair an inflamed tear in somebody who has no muscles. So if they have very vigorous fatty replacement of the muscles and small muscle volume, you must comment on that because you don't want to repair those individuals. You want to leave them alone and let the rotator cuff just scar down. Now, this is a 70-year-old. He's skiing. Should we fix this? And my answer is, yeah, I think this is a candidate even though he's 70. If he's otherwise healthy, this is really inflamed, lots of bursitis. It's penetrating. If he has undergone a reasonable trial of rest and physical therapy for 6 to 8 to 9 months and it hasn't gotten better, then surgery, if he's otherwise healthy. But I would give him that 6 to 9 month trial because that could scar down if you ice the heck out of it and all that inflammation could go out of it. So what's the conclusion going to say? Near full thickness, but penetrating tear with both central rim rent and horizontal bursal-sided extension with or without communication, inciting active bursitis, active tendinopathy, and active bone marrow edema due to the rim rent component, number one. Number two, subacromial arch stenosis and/or impingement, predominantly due to coracoacromial ligament hypertrophy. Number three, relative preservation of muscular size with only mild decreased muscular volume and no fatty infiltration. Number four, mild or at best moderate osteoarthritis of the glenohumeral articulation with chronic degenerative tears and/or fissures of the anterior and posterior labra and mild conformity change. That's how that case would get read. Good question. I actually didn't think of it, but would they do anything with the biceps pulley? If they operated on the rotator cuff, my guess is they would probably tack this back down, but I'm not 100% sure of that in a 70-year-old. Now, if it was a 30-year-old, for sure, they'd tack it down. In a 70-year-old, they might leave it alone. So the honest answer to your question is I don't know. I think it would also depend on whether he has anterior symptoms. You know, it isn't a bad pulley problem. And, you know, messing around, you know, in here kind of complicates the surgery. So the answer is I don't know in a 70-year-old. 30-year-old, for sure, they deal with it. Should you comment on the glenohumeral ligament complexes? Of course, in the proper setting. Do I routinely comment on the superior, middle, and inferior glenohumeral ligaments in a regular standard shoulder report in a non-dislocator without macro instability? No, I don't. You know, I'll say the capsule is normal, so I don't specifically call those out. Now, in slap lesions and dislocations, I absolutely will call them out one by one. And here's the biceps labral anchor. Most people have a very small or diminutive superior glenohumeral ligament. This one I'm having trouble seeing. Let's see if we can see it sagittally. Here's the biceps coming at you. There's the superior glenohumeral ligament right under it. So I can't see it in the sagittal projection. Here's the MGHL, which is very linear. It sits right underneath the subscapularis. And then when it becomes more arcuate, it's still straight, still MGHL, MGHL, and now it makes this arc-like turn and gets a little fatter. Now it's IGHL, anterior band. There's also going to be an axillary band and a posterior band. A sore shoulder. Okay, so the last case, even though they were 70, you know, in the right setting, failed a conservative trial, pretty good muscularity for a 70-year-old, arthritis not too bad, you know, still very uncomfortable, would consider surgery, even though shoulder surgery is a big deal. If you've ever had it, I haven't, but, you know, it's no small trick. It's much more challenging to recover from shoulder surgery than knee surgery. Patient was a little uncooperative in the axial projection. This was done on a 1.2 Tesla open. And just as we did before, we start up high, and this time our rotator cuff is not visible. We don't see those linear fibers tracking over the humeral head like we did in the last case. We see some gray to white tissue. Here are some reasonable fibers in the back. Let's work our way down. So it looks like the humeral head may be bald. We're also noticing the massive muscular atrophy in the back. That's either edema or atrophy. If it's atrophy, we've got a problem. Let's go back there. Well, it's probably not it is atrophy, but it's volumetric atrophy, but not that much fatty replacement. There's fatty replacement at the myotendinous junction. Let's keep working our way down. Some glenohumeral arthropathy, degenerative changes and chronic tearing in an adult 56 in the posterior labrum. Honestly, most people have something like that. Anteriorly, we've got delamination of the subscapularis again. This time we have a very sick-looking, irregular, remodeled bicipital groove. There's the transverse ligament. There's a break in the transverse ligament. So another pulley problem, very common. So delamination of the subscap. Biceps is present. Hasn't really come out yet, but it will. It'll eventually sublux. So I like to see the biceps come out after the subscap disappears. Now look at the subscap detachment here. That should be over here on the lesser tuberosity, tightly attached with the MGHL, which did attach. That's the MGHL, which travels with the subscap. The SGHL travels with the biceps. So as we go down, the biceps looks a little irregular and a lot sicker, but we've got bigger fish to fry. Let's pull down the sagittal. So here's an easy one, very gross example of a rotator cuff tear, 56 years old. Are we going to fix this? This is a huge tear. The length, first of all, full thickness, depth, full thickness tear. All right, let me make them a little bigger so it's a little easier to see. So now we're on yellow, and there's our tear. Wow, that is one big tear, all filled in with fluid. It's got some of the anterior fibers of the infraspinatus. The infraspinatus interstitially looks awful. So how would I describe that? Interstitial tendinopathy and tendon fiber failure of the infraspinatus with loss of some of the anterior fibers and a complete, lengthwise, anterior to posterior, full depth, full thickness, supraspinatus rotator cuff tear with a medial lateral retraction dimension of X, measure that, and severe tendinopathy and tendinosis of the retracted fibers, which is your way of saying, hey, you want to sew that back, that's some bad tissue. How do you get that tissue back all the way over there when it's so sick? You may not have enough of it. You also have fatty infiltration of the myotendinous junction. You've got muscular volume loss, and you've got really nasty impingement. It looks like the keel of a boat or the end of a telephone butt, a telephone receiver or keel like acromion producing outlet-related impingement. So she's got anatomic subacromial impingement, a large full-thickness, complete supraspinatus tear, 4 centimeters AP by 4.5 centimeters retracted with severe tendinopathy or tendinosis of the retracted tendon ends, period. Next paragraph. Severe interstitial tendinopathy and multiple micro tears of the infraspinatus mid and posterior fibers, period. Dissection into the posterior myotendinous unit of the infraspinatus consistent with a sentinel cystic tear. Number next. Teres intact, but the subscapularis is detached with a full thickness tear, but incomplete. Right? Only the upper fibers were off. And an injury to the biceps pulley mechanism with tear of the medial transverse ligament, but no biceps dislocation. Next paragraph. I probably would put the AC joint arthropathy in the body since she's got so many other problems, but I would say moderate to marked arthropathy, and then I try and determine the degree of inflammation on the T2, not the PD, because everybody's AC joint is swollen on the PD. So if it was swollen on the T2, which I do not have, actually I've got a kind of a poor person's T2, it is swollen. So I'd say mild to moderate active inflammation of the AC joint. And then I probably would bury the glenohumeral arthropathy in the body of the report, describe it as moderate, but that there is class 4 chondromalacia in the inferior glenoid and chronic degenerative changes and fissuring of the posterior labrum. Are there any questions about this case? There's our chondromalasic ulcer seen on FOSS. So this is one where I wouldn't operate. It's a massive tear. How are you going to get the tendon over? The tendon that you have is sick. The muscle that you have is kind of borderline sick. There's fatty infiltration. You're going to have to do an acromioplasty. You're going to have to do a Mumford. What percent of surgeons would attack this case? 50%. What percent of radiologists like me would attack this case? 2%. Okay, let's start with our axial. You can see some tendon fibers here at the end. Now, a lot of surgeons like to describe their tears arthroscopically as U-shaped tears. You know, if you lose this part of the cuff, or L-shaped tears if you lose this part of the cuff, or C-shaped tears. So they often describe them from the top down, and if you have good quality axial imaging, you can do that. As we work our way down, there's inflammation mostly in the infraspinatus, less so in the supraspinatus. The entire infraspinatus muscle is edematous. So what could cause that? Quadrilateral space syndrome, Parsonage-Turner syndrome, also known as brachial neuritis, and an injury. Although for an injury to get the entire infraspinatus, you know, that'd be a little unusual unless you can find a focal area of concentrated separation of fibers. And maybe that's it right there. Did have an injury after lifting lumbar, so that wouldn't be unreasonable. Let's keep going, shall we? Let's put up all 3 coronals, and then we'll toss up the sagittal. Let's get them nice and big. So we've got a T1, a T2 without fat suppression, and what is supposed to be a PD. And let's scroll. I'm going to move mine over a little bit so you can see it. How are we going to describe this thing? Okay, I'm going to give you the infraspinatus, and I'm going to give you the fact that there's a differential diagnosis. The reader chose Parsonage-Turner syndrome. I would have chosen an injury because of how concentrated the signal is right here, and I've seen a gazillion cases of Parsonage-Turner, and the whole muscle looks exactly the same. Swollen, medial, lateral, superior, inferior, exactly the same. So the fact that it's concentrated focal edema tells me, especially with the history of lifting lumbar, that is part of the patient's injurious event. But we're not done yet because we're on the rotator cuff. We've got this weird thing here that is somewhat saucerized and linear. By the way, it's in the infraspinatus. I think we're in the back. We are. And it's still here. You see it on the PD spur. You hardly see it on the T2, and that's why T2 isn't the detector. It's the refiner. The T1 isn't the detector either. It's for anatomy. It's for morphology. It's for the subacromial arch, the medial arch, the subcoracoid arch. So what should we call this thing? It's in the back. It's got a weird shape. It's got a little bone penetration. It's linear again. It's coming forward. Then all of a sudden it turns vertical. And where does it do that? Let's see where we are. I mean, what are you going to say about something like this where you have dots and spots everywhere, huh? See where this thing is. It's in the supraspinatus. So we have supraspinatus involvement. It's pretty penetrating. We have infraspinatus involvement. It's one tear. Very saucerized in the front with a vertical component. Near full thickness. Small but deep is a term I like to use often. Because if you use high grade, to a surgeon that means, well, it's a 3-centimeter tear. So I don't like to use the term high grade. I like to convey the sense of what it looks like visually if they don't have to look at the film. Because if they have to look at every film, you're going to be out of a job. So I'm going to tell them that it is a small tear anteriorly. It's got a vertical penetrating component. It's near full thickness. You can see it may spill out. You can say near full or full thickness, but pinhole-like as it traverses posteriorly with a circuitous course and then becomes a horizontal interstitial infraspinatus tear that dissects medially. And what is that called? It has a name. It's called a novel lesion. Don't ask me who made that up. But it basically is a tear that defies description. Okay, that's fair. What are some of the other kinds of tears? Well, you could have an intrasubstance concealed tear right here, like that didn't penetrate. And that would be called a concealed interstitial delamination footprint tear, or a CID. If it penetrates the bone, then it's a CID with a rim rent. What if your tear then decided to do this? You'd say I have a CID with a rim rent, say it's in the bone too, but with medial interstitial extension. Now that is not an articular-sided tear. There's no joint space there. Joint space doesn't start till over here. That's the footprint. That is a humeral-sided tear, not, I repeat, not an articular-sided tear. Why is that important? Put a scope in, don't see it. It's not in the joint. Now over here, that would be an articular-sided tear had it been there. It's not there. You had a tear there? That would be a small articular-sided tear or a supraspinatus tendon articular-sided tear known as a Stoss lesion. Supraspinatus tendon articular-sided. But if it decides that it wants to go interstitial on you from there, now it's a paint lesion. It's a partial thickness, articular-sided, interstitial tear. Oh, we're not done yet. There's more. But I'll tell you what, it's time for lunch. So you've had a novel lesion, a CID, concealed interstitial delamination, a CID with a rim rent, an articular-sided tear, a Stoss lesion, a paint lesion, a partial articular-sided tear with interstitial extension. You've seen a full-thickness tear. You understand the concept of length, front to back, width or retraction, medial lateral, and depth, which is intuitive. And you should have all of those facets in your discussion of the rotator cuff and describe the muscularity and the presence of fatty infiltration and the presence or absence of subacromial or subcoracoid arch stenosis and the overall status of the joint, its conformity, and look at the centering. People that have rotator cuff insufficiency, the humeral head goes up. This one does, right? It's decentered. There's the scapulohumeral line, should be down here. Loss of the normal depressor mechanism from rotator cuff insufficiency, and usually weakness of the shrug mechanism.